think about the premaxilla or the molar sides. And very often, and this is actually the reason that we are extracting teeth. Why? Trauma, infection, periodontal disease. These are the three major issues. So we are facing very often infection, even in some cases that doesn't show any. But there's a contamination, or at least an infection potential. And this infection potential actually will be represented by the presence of these famous sharper fibers. These sharper fibers, we all know these. They are part of the periodontal ligament. And when you're taking out the tooth, when you're using your curette, Lucas curette, for example, and making this debridement of your socket, don't you think that you leave some part of this ligament? Of course. Of course, all of you. And very often, and because of this socket profile, you have, or you're facing a problem of primary stability respect to the atrophic shape. And the other problem we're all facing is this gap. And the main question, again, is shall we fill the gap or not? And how can we avoid of filling this gap? I will show you this. But maybe one of the good answer to this will be the right choice of the healing implant. If you are working in two-stage in one, that means that you place your implant, immediate post-extractive, and either you place your healing cap at the same time, or now, which it happens to me very often now, is going to immediate loading at the same time, then using or permanent abutment or provisional abutment. You will try by this emergence profile to fill up this gap. And the right choice of your abutment or your healing cap will direct the choice of both diameter and the height of your prosthodontic connection. So solution, implant that allow bone connection, expansion or spreading. Actually, a lot of publications are using different terms that means exactly the same. An implant with a strong anchorage on the apical part, surgical procedure that will facilitate the implant of your, the placement of your implant. Of course, if you want to expand the bone, if you want to have a good stability, primary stability, then you will have to apply a high torque, and you will see that it's possible. And the right placement of the implant in depth, and the choice of the healing screw like we talked about before. And of course, this is the issue, the management of this soft tissue. And this is what we're going to try. All of you are young here, but you probably have heard about the hysterical part of this GBR technique with the use of Gore-Tex membranes. And this is what we're going to try. Complication because of use of an inadequate or choice of inadequate soft tissues, a weak in primary stability, and often due to the placement of the implant too deep or too superficial. And a damage of fenestration of the buccal plate and protected implants. Anyway, let me go to the technique. The technique represented by flapless. Flapless is fundamental. But even if flapless have an issue in terms of scars or resorption, both on hard and soft tissue, we know that since we're working with surgical navigation, think about surgical navigation systems. Actually, I gave you here some different publication, recent, and I don't want to go deep in these different publications, but they all, and I summarize here, what they all say. The advantages, including the preservation of circulation, soft tissue architecture, hard tissue volume and design, decreasing the surgical time, improving the comfort of the patient, and accelerating the healing. But all of these are coming from the blood supply. And this is because in guided implant surgery, we're working flapless, that we have good results. Actually, that's another topic. I'm not that sure that there are so good results that this has been demonstrated. Anyway, but it comes because of the preservation of the circulation, the preservation of this blood supply, which is fundamental. Again here, numerous publications about flapless surgery, and they all conclude in rising the primary stability, gaining in bone density, which is logical. If you can dense the bone, then the density will shift from D4 to D3, and maybe to D2. And we raise this famous BIC, bone implant contact, the surface between the implant and the bone. Just gave here just one conclusion of one of those publications. Flapless surgery procedure for dental implant is advantageous for preserving this crestal bone and mucosa health. And technique increased the success rate of dental implants. I was published in Journal of Evidence-Based Dentistry in 2012. We shift to this soft tissue management. Soft tissue management is a critical issue. And actually, that was one of my first mistakes that I did clinically. Because at the same time, I wanted to avoid the use of biomaterial. But at the same moment, I wanted to have a nice healing. Because remember that very often we are facing a problem of a gap, of a leakage. So these are coming from different surgery, two-step in one, and this is the healing cap. Other with the choice of the healing cap by the diameter and the height of the healing cap. And this is just after extraction, different aspect, different clinical cases. In some of the cases where, for example here, first molar is missing. So the problem is here to avoid this gap within the soft tissue. And in this case, I will show you, but even the choice of the healing screw with the diameter and the height of the healing screw is not sufficient to close your soft tissue. Because what? Actually, what is the best membrane? The best membrane is represented by the periosteum. We all know this. It's not whatever kind of membrane you're using. This is the periosteum. But we do need to manage